Craig, welcome to the Warden Tech Talks podcast.
Thank you for having me.
Thank you. Thank you for joining us. Before we begin, let's start with a really fun hook. What's something about you that no one can find online, something they can only learn by listening to this episode? We'll save your answer for the end.
All right, I'll have to think about that.
Welcome, Dr. Craig Joseph. Craig is the Chief Medical Officer at Nordic Consulting, an expert in healthcare IT, and co-author of Designing for Health, the Human-Centered Approach. He spent decades at the intersection of medicine and technology, optimizing EHR systems and improving physician workflows. But before we get into your career, Craig, tell us a bit more about your background. Where did you grow up and what were your early interests?
Sure. Let's see. I was born in Detroit, and when I was 9 or 10, moved to Miami, Florida. I get in trouble because sometimes people ask me, where did I grow up? And I give different answers. Sometimes it's Detroit and sometimes it's Miami. And I have been called out for that. So I'll continue to do that just to confuse people, keep the police off my trail. I went to junior high school and college in Miami, went to University of Miami for undergrad, and then moved back to Detroit, where most of my extended family was, for medical school, and did my residency in Detroit at Children's Hospital of Michigan. I'm a pediatrician. And then practiced primary care pediatrics in the suburbs of Detroit for about 9 years before moving to the dark side and going to work for an electronic health records vendor. And since then, I've been on the provider side. So I've been the Chief Medical Information Officer for a number of hospitals, either on an interim or a long-term basis. And as you mentioned, I've been now almost 5 years at Nordic Global, which is a healthcare management consulting firm.
Interesting. I'm really curious about that transition you made from practicing as a pediatrician to transitioning into clinical informatics. What led to that shift and what was the biggest learning curve when moving from direct patient care to healthcare?
It's a good question. I tell everyone that I was burned out before it was cool to be burned out. I didn't enjoy the administrative part of practicing medicine. Back when I was practicing 25 years ago, at least in suburban Detroit, Michigan, pretty much everyone worked for a small practice. So like a big practice was 6 or 7 doctors. There wasn't a Kaiser Permanente or a really large practice. There was one, but most physicians, when they finished residency, would just go out and either open up their own practice or go join a colleague. And it was a small thing. And so I was mostly with 2, 3, 4 doctor practices. And what that meant, at least especially in pediatrics, which is the least paying of all the medical specialties, there were ample times where I was spending a lot more time on administrative problems, 2 nurses who couldn't get along, fighting with vaccine companies. And so there were times where my partner and I couldn't pay ourselves because we were waiting to get paid ourselves. There was a lot of stress. I was looking to do something else. And I thought, hey, can I spend a lot of time, money, and sweat equity in learning a clinical specialty? And can I leverage that with something else that I'm good at? My undergraduate degree was computer science, which I started college in 1986. That's a gazillion years ago, I think. And that was very uncommon to have someone be pre-med and have a computer science or be working towards a CS degree. So I had that. So I thought, hey, if I can combine my technology skill set with my clinical experience, might be something. And so I ended up getting hired by Epic and moved my family from Michigan to Wisconsin. It was a very unusual thing to do at the time. I think it's much more common now for physicians to either stop practicing fully or actually more commonly to practice a little and do something else as well in business. But back then, your choices were practice or retire. Those were the 2 choices that you had. When I announced that I was leaving practice and moving out of state to go work for a software company, I had many physicians come out of the woodwork who I barely knew. And they're like, I can't believe you're doing this. And I said, yeah, I'm doing it. And ultimately, the conversation came to, boy, I wish I could do that. Over the course of 5 minutes, it started off with, you're crazy. You shouldn't do this. And ended up 5 minutes later, I was like, boy, I wish I could do it. And of course, they could do it, but they didn't feel that the juice was worth the squeeze.
Interesting. Before we talk a little bit more about Epic and Cerner and your experiences there, I'm actually really curious. I'd love to dwell a little bit more on your medical training. What spurred your interest in pediatrics specifically?
My main requirement for a specialty was that my patients be shorter than me. And I'm not very tall. So that really limited my choices. I think if you ask most physicians, they'll all have an interesting story. I went to medical school to be an emergency medicine doctor. That was my plan. I was going to go do an emergency medicine residency and work in the emergency department. I was an EMT in college. Like I did all the things emergency related. And then I spent a couple of weeks in the emergency department in downtown Detroit, an academic, they called it the Knife and Gun Club. We saw a lot of trauma in Detroit in the 90s. And I was like, oh, actually, I don't like this. This is not what I thought I was going to be doing. It was like 95% incredibly boring and 5% people trying to actively die in front of you. It just didn't appeal to me. And I don't know, I stumbled into peds. It wasn't like I've always wanted to be a pediatrician. It wasn't that I had a doctor who, when I was a kid, who was a mentor to me. I like hanging out with kids. That sounds bad, but kids are generally so honest. If they're doing something, they'll tell you that they're doing it. And it's the opposite of most of us adults. So like, no, I'm not smoking. Oh yeah, I exercise all the time. I guess I am saying that most of us adults and the truth from time to time, especially when we're talking with docs, kids were just transparent. They tell you what they think until they become adolescents, and then it's all bets are off. I enjoyed working with parents. I enjoyed working with the kids. I like the kinds of issues that we could deal with. One of my standard lines with most parents was, in general, children get better despite anything I do for them. My major job was to do as little as possible for as long as possible, which I think is completely different in primary care for adults. But for kids, my main job was to try to calm the parents and tell them, no, I don't want to do blood work. No, we don't want to get an x-ray, because that's going to lead us often down a path that doesn't help anyone. Now, that doesn't mean don't do those things if there's a reason to do them. But often there was really no reason. The likelihood of anything wrong was very low, and the benefits did not outweigh the disadvantages of testing.
Super interesting. Before we get into talking about this transition that you made into clinical informatics, I'm also really curious to return to the foundations of your interest, the genesis of your interest in technology. So you were a computer science major.
Yeah.
Where did that interest come from?
I tell you what, I started programming at Radio Shack, which is a company that doesn't really exist anymore, but they used to be ubiquitous. There were Radio Shacks everywhere. And in the early 80s, they came out with this thing called the TRS-80 color computer. And it cost $400 in 1983, 82, something like that, which was a lot of money. And it had 4K of RAM. So I just want to be clear to your audience. 4K is a small amount of RAM. There was no disk drive. Ultimately, they came out with a disk drive, but I could not afford that. So if you wanted to save programs or access data, that was done through a cassette recorder. I'm telling you, it was a long time ago. Anyway, I convinced my mother to drive me to Radio Shack to play on this thing. And they had a pretty good manual to teach you how to program in BASIC on the computer. And I remember vividly my mother trying to get me to leave. So I was probably, 12, 13 years old. She was trying to pull me out of the Radio Shack store. And she was like, you cannot stay here. You can't just sit here for hours in the middle of the Radio Shack on their demo computer playing around with it. And the store manager came over because he heard this conversation. And he said, ma'am, actually, he can't. I'm selling computers because this kid is sitting here and these adults are like, if the kid can do it, I could do it. And he said, you drop this child off for as long as you want. And ultimately, my parents got me that computer. And I learned so much off this little garbagey TRS-80 computer. I learned how to code efficiently. I learned assembly language, which is really understanding how the computer worked at the most basic level. I learned a ton of that. So going into undergrad, I wasn't sure what I was going to major in, but I knew I wanted to be a physician. So I was pre-med, but you don't major in pre-med. It's a way of life, not a major. So you have to major in something. And when I was a freshman at University of Miami, the dean for admissions for the medical school came and spoke to all the freshmen who thought they were going to be pre-med and just gave an overview and answered questions. And one of the questions that she got was, what should we major in? And I was like, oh, that's the question. Yes. And she said, most of you will major in biology or chemistry. And if you're very interested in biology or chemistry, that's awesome. You should major in that. But if you want to draw attention on my desk and you want to stand out in front of me, which you probably should, that would be an art major or an English major or a non-traditional, non-science major. Now, of course, you still have to take at the time, most medical schools required 2 years of chemistry, 1 year of biology, 1 year of physics. That was it. If you took those classes and took the MCAT, you could apply to medical school. I was like, I will do the thing that will be the easiest for me to get good grades. And that was computer science. Now I tell people, hopefully no one's listening to this podcast, because what I tell people generally is, oh, yes, of course, I've always known that I was going to combine my technology background with my medical skills. That's a lie, but I do tell them that from time to time. I thought it would be easy. It was easy. I tell people I really didn't learn very much in college with respect to computer science because I'd figured out most of the stuff on my own, just on this little computer. It was because, again, computer science was just a much smaller discipline back then. I graduated without an email address. We didn't have email, just to give you some sense of where we were back in the day. That's how I got that CS degree. Let's be clear. I don't program. I'm not a coder now. All of that technology experience really gave me a good ability to call BS. And that's really all I need for my job is when someone tells me something's very complicated, I'm able to go, is it though? Is it?
Yeah.
Because I don't think it is. It sounds like this should be pretty easy. Why do I think this should be easy and you're telling me this is complicated? That's super helpful in my job.
And that's a perfect transition to the next issue that I would love for us to talk about, which has to do with the present day and some of the systems that we're using and some of the frustrations that are present in those systems. So you've spent about 20 years, over 20 years working with EHRs like Epic and Cerner. If you could wave a magic wand and instantly fix one of the major issues with the EHRs today, some of these problems that seem intractable, also to your everyday person seem like they should be solvable. But within the industry, lots of smart people working very hard to solve these problems still haven't been able to solve them. What's that one thing that you would try to resolve with this magic wand?
The magic wand would not involve technology. It would involve policy. I think that the major problem with software that physicians are using today that they're complaining about is that they're practicing in the United States. I'll pause on that. When I worked at Epic, and again, for your audience, Epic is in the US now, I think the largest electronic health record vendor. Most of the academic medical centers are pretty much everywhere. That's a big system. I got an email once when I was an employee saying, hey, do any of you physicians, there were about 10 of us, do any of you physicians want to go to Amsterdam for the first European Epic go live? And all of us were running to our computer, to our keyboard as fast as possible. Yes, please. Anyway, I watched how the Dutch used the same software. It was modified, of course, for their particular use. But I tell the story that I was in a group of physicians, and most Dutch, especially professionals, speak English, some better than others, but they all speak a little bit. And they were asking me about this one tool that helps document in a standard way a physical exam. And they were like, we don't understand it. Maybe 20 of them. We don't understand this thing. I said, let me explain. And this is how you could document quickly a very complicated physical exam. And they're all just still looking at me, questioning with the kind of a questioning face. And then the guy with the best English said, no, we still don't understand. I said, let me explain to you again. And I started explaining and all the heads were going back and forth. And then there was a bunch of conversation in Dutch that I didn't understand. And he looks at me and he goes, we still don't understand. Why wouldn't we just say physical exam normal? That's what we want to say. Why wouldn't we just say physical exam normal? And everyone, all of their heads started bobbing up and down. Yes. And I started laughing. I almost had to leave the room. I was laughing so hard. And I was like, because we can't do that in the United States. We really can't. Now, maybe we can under the newer CMS guidelines to some extent, but certainly at the time, that was a no-go. That proved to me what I said, which is, hey, that's not a software problem. You practice in an environment, you doctor, practice in an environment in the U.S. It's not only the U.S., but it's the U.S., where we physicians have been subsumed by lawyers and regulators and governments who are sometimes trying to help and sometimes are working towards their own benefit not trying to help the patient or the physician, in my opinion. Yeah, the one thing would be to change the requirements under which we practice. Documentation and is one of the major things, but the way malpractice works in the U.S., where physicians are judged ultimately by a jury, not of their peers, but of folks with no medical experience. And again, I might come off sounding, you doctors, you want to be the judge and jury. And no, but there should be some cross between, I wouldn't want to judge a civil engineer on what they do. I don't have any insights there. Yet, if they were accused of doing something wrong, that's exactly what would happen if I got called to jury duty. Long and short of it is, I don't think it's a technology problem that most people complain about. It's a policy problem, and physicians are rightfully complaining that they have to do all of these things that they don't see any benefit to either them or the patient. And oftentimes the software works that way so that you can do all the things that are required of you by a big healthcare system that is situated in the US. And it's not that the software developers want that to be the way. Again, that said, Epic and all the others can absolutely improve. And I'm happy to throw them under the bus when it's appropriate to throw them under the bus. But often it's not that. I'll summarize all of that to when people complain to me about certain things, the most common things. I reply with, do you enjoy practicing medicine in the United States? Because if you're willing to relocate, I can solve most of those problems for you. With the exact same software, I can solve those problems. And it lets you write a note to say, physical exam normal.
That's incredibly interesting. So you're saying the biggest feature you would change with EHRs is actually the policy framework within which they operate.
No, I wouldn't touch EHRs. I would say if we change the policies in which physicians operate and hospitals operate, then the software could pretty much overnight be so much better.
And the experience of using it, of course, would be better as well.
We all want it should just be as hard as using my phone. Okay, but your phone gives you many choices, and we don't have some of those choices in the US. It's neither here nor there. But yeah, so I think it's not the technology. Again, there are going to be people who will bring up this is bad and this is bad. Absolutely true. But all of those pale in comparison to regulatory and compliance reform.
Interesting. Okay.
Am I going to be arrested now? Do you think I'll be arrested?
Not at all. I think you get a free pass on this podcast, at least.
All right, great.
I'm really curious to lean into this topic a little bit more and talk about what can be done to improve, given that regulatory environment isn't going to change overnight, right? Given some of those policies might take time to evolve and find the right balance between what makes life easier for physicians and also what ensures a certain degree of quality of care, a certain standard of quality of care. I'm curious, because you've served as an interim CMIO at multiple hospitals, what's a really common mistake that hospitals make when they're implementing or optimizing the EHR systems, particularly keeping what works best for physicians in mind?
Yeah, I co-wrote a book called Designing for Health. So that naturally my answer is going to be design. I think the biggest mistake that folks make when they're either creating an EHR or implementing, when we say implementing, we mean configuring. Because once you've seen an Epic implementation, you've seen one Epic implementation. They differ based on decisions that hospitals and healthcare systems make. I think that we often forget in healthcare just basic human-centered design principles. If you want to make it easy to do the right thing, you want to get rid of stupid stuff. You want to make sure you understand who your audience is and who you're trying to target with the software changes or ideas that you're making. These are basic things. When I give talks about this, I often talk about the door. I don't talk about technology at all. I always start with a door. And I posit that any door that requires instructions for use is a poorly designed door. If you have to tell me to pull or push, that's a design problem. If I come to a door and it's got a flat metal panel on one side and on the other side it's got a handle, I'm pretty sure I know what to do. I'm going to push on the flat side and I'm going to pull that handle on the other side where there's a handle. But often we come to doors that have handles on both sides. One of those is wrong, mostly. You don't need a degree to figure this out. Just sit and watch for 5 minutes and watch people go and they'll pull it and it won't move, and then they'll push it. So they had a 50-50 chance of getting it right. They didn't get it right. We do those kinds of things with electronic health records. We don't add defaults where defaults should probably exist. So what do I mean by that? I think one of the tenets of design is to make it easy to do the right thing. Everyone would agree with that. In medicine, especially in the United States, the difficult part is deciding what is the right thing. I use this to my advantage all the time when I'm doing my work. I say, listen, I've got the easy job. I just have to make it easy to do the right thing. You all, clinicians and operations leaders at healthcare systems, you have the difficult job. You have to tell me what that is. For community-acquired pneumonia, we know that our hospital in this area, this is the antibiotic that we would like most people to start with. It's relatively inexpensive, and it works against the bacteria that are causing the problems most typically. If you give a doctor 3 or 4 choices in an order set and just leave it blank, 3 or 4, and then let them pick, they're often going to pick the wrong one. Not that it's wrong and that it's unsafe, but it's, that one's very expensive, or that one's very powerful. It's probably not needed for this patient. Make it easy to do the right thing. So if you decide, doctors and hospital administrators, that the right thing is antibiotic B, and that most of the time, not all the time, but most of the time, antibiotic B is the right answer, then we should default that so that when the doctor goes to it, it's already chosen for them. Now, does that mean, now doctors don't have a choice? Nope. All they have to do is click another button and they can choose a different antibiotic. But most of the time, they're not going to, because most of the time they're going to be like, yeah, that's fine. That's fine. That's probably the right one. You can dramatically improve the right thing being done if you can decide what the right thing is. Just something as basic as that, we often don't do.
That's really interesting. I think that's a really clear example of how the right defaults can lead to actually improved outcomes for patients and reduced effort or reduced exhaustion for clinicians. I'd love to hear another example of a time when thoughtful design dramatically improved clinician workflows or patient outcomes.
I'm going to push back a little on your question with the word dramatically, because I'm going to argue that we're generally not looking for dramatically improved workflows. We're looking for tiny, marginally improved workflows. Small changes which often make a big difference, because it's the tiny little cuts, the death by 1,000 cuts that are killing most of our clinicians. And it's not a big deal. I'll give you another example. This is from the book. I took my daughter she was getting headaches. She was a young girl and she was getting headaches. And I took her to the academic medical center where we lived. So essentially a children's hospital, office building associated with the children's hospital. And they were using Epic. And they had implemented it maybe a year prior. Of course, I'm much more interested in watching the nurse room my daughter than most parents. So I'm keenly observing everything that's happening. And she said, why are you here? And I said, well, she's having frequent headaches. And I watched the nurse do this. She goes into Epic and there's a field called reason for visit. And it's got a bunch of choices. You can choose from one of 100 things in there, or some number like that. And then next to it is a free text box. And I said, she's here for headaches. And the nurse says, great. And she goes and types in other in the list. She chooses other because headaches wasn't on that list. And then she types headaches in the free text box. And I stop her and I'm like, so this is a pediatric neurology clinic. And she goes, yeah, it is. And I said, do you see, I knew the answers to all these questions. I said, do you see a lot of kids with headaches in the pediatric neurology clinic? Of course they do. She goes, yes, of course. And I said, but how come that's not a choice on your drop-down list? And she goes, I don't know. It's not a choice. And so we type in other. And then we type in over there on the right. And I said, did you tell someone about this? And she goes, I don't even know how I would do that. We used to do that when we were going live. There was a piece of paper, but nothing ever changed. Why would we even do it? Now, what she didn't know was that it was super easy to add headache to the list. And what she also didn't know that I knew, because I worked for the company that made the software, was that if that choice was there, what it was going to do was it was going to serve up for her on a silver platter, her and the physician, documentation and orders related to. So if there's an order set for headache, that would pop up. If there were documentation templates for headache, those would automatically pop up for her.
They're pre-populated.
She wouldn't have to go looking for them. And again, was looking for them the end of the world? No, because she would just go there and type headache. But one less thing to think about. And she didn't get any of those benefits because she free texted the word headache. And when you free text, it's useless at that point. Now with AI, we're getting a little bit smarter. But so it's these little tiny things. To me, the message to take home from there was, if you don't make it easy, again, we want to make it easy to do the right thing. Okay, the right thing is make it easy to have your users, your doctors and nurses and physical therapists, make it easy for them to tell you about problems in the electronic health record, or any of the work and any of the systems that people use for work. Make it easy for them to give you that feedback and then make it transparent, another part of design.
Okay.
If I send you a note saying, hey, this is broken, I think, and maybe it's not broken, maybe it's actually working as designed and there's a reason for it that you don't understand, ignoring it or closing it without getting back to the person that sent you, then they're never going to send you anything ever again. So you have to be transparent and say, oh, thank you, we fixed that. Or, oh, actually, there's a policy, there's a law that says we're not allowed to do what you want us to do. We would love to do it, but we're not allowed to.
Gotcha. Okay, so those are some of the opportunities for improvement. Like you mentioned, there's the smart defaults, there's making sure there are opportunities for people to provide feedback. So the software can be customized over time to reduce the amount of effort involved in using it. And then making sure that you're closing out effectively on those requests when they come in, those requests for customization. So you can just encourage people to continue providing that feedback so they don't get feedback fatigue. You mentioned AI, and this wouldn't be a technology podcast if we didn't talk about AI. I would love to hear where you see AI making the biggest impact in healthcare IT over the next, say, 3 to 5 years.
We're already seeing it, so you don't even have to predict it. It's in the administrative part of medicine that no one likes, but we all admit we have to do some of it. So it's in the documenting of office visits. It's in the creating of billing codes, accurate billing codes. It's clinical decision support, suggesting to doctors things that they might want to do. We're seeing those things already. I'll tell you where it's not, though. It's not in diagnosis. I'm a firm believer that physicians will not be put out of work because of an artificial intelligence. In fact, what I'm hoping it will do is free us to do what we used to do, which is spend time talking to patients and examining patients. And so, yeah, it's all the administrative stuff that, again, if we want to get paid, we have to bill the insurance company or the government. And there are codes to do that and all kinds of rigmarole that we have to go through. And we don't really need to do that. If a computer can do that, would be awesome. It's not that you walk in and you talk to the computer or that the computer diagnoses you with a problem. That's not where AI is by far right now.
Interesting. So it's not quite as involved right now in clinical decision making. It's really more about reducing the burden of administration.
Yeah, it's involved in clinical decision support, but not involved in clinical decision making. I like what you just said. The main reason, again, in the United States is that you can't sue an AI. It sounds ridiculous, but if something goes wrong in healthcare and you think someone made a mistake, there needs to be someone to sue. And if it's the computer that made the mistake or gave you advice that you took and it didn't turn out well, there needs to be someone who's responsible for that. And I don't know how that goes away. Ultimately, I think AIs can help us by saying, hey, you didn't consider this. Or were you aware of this lab result or this x-ray? Or it's very unlikely, but there's this thing, this other disease process is on the list of the differential diagnosis. That's super helpful. But ultimately, at the end of the day, it's the physician who's going to make a decision and going to be held accountable for that decision or that recommendation. It's not going to be the computer. It can't be.
That's fascinating. Would you say that in the same way that the way that EHRs are used at present is constrained somewhat or determined by policy, that the use or the proliferation of AIs in clinical decision making is actually limited not so much by the capabilities of the AI platforms themselves and more so by the legal structure around it?
I'll just tell you a quick story. So first, 100% yes. 18 years ago, Epic produced some software so just imagine physicians going through an office visit or an emergency department visit and documenting and putting in, I looked at the heart, I looked at the lungs, I ordered this lab test, I looked at that x-ray, and they're documenting this in a discrete way. Now with AI, we probably don't need all that discrete data because AI is smart enough to look at the bigger picture, but 15 years ago, absolutely not. We needed all these boxes checked. And there was software that I assume still exists that was basically giving a running play-by-play to the emergency doctor saying, if you document one more body finding, so you did heart, lung, skin, eyes, ears. If you did one more thing like muscle, the code will go up one. The amount of money that you'll be able to bill the payer, the insurance company, will go up a notch. That was never implemented. Customers never took that software and turned it on. And the reason was they're like, wait, it sounds like you're encouraging the emergency doctor to examine or document that they examined part of the patient for the only reason of getting more money. And we don't want to do that. If you're asking me, is there software that could be implemented that's not implemented because of policy restrictions, not technology? 100%. We could do a ton of things. Now, was that a good idea to turn that offer on? I don't know. That's not for me to decide. I could argue that if they're going to document it anyway, just good for them to know where they are as a running kind of commentary. But I could also say if there's someone who gets paid based on the codes that they drop, some doctors are paid that way. If they have skin in the game, you're right. That might incentivize them to order a test that's not necessary. or to document a body system that they weren't going to document beforehand. So I get it. But yeah, we've got all kinds of technology that we could use that we choose not to use.
That's a really fascinating area to keep an eye out for over the next few years. I think there definitely are going to be lots of evolutions in there. I think there probably is a lot of money at stake, and there will be some company, I think, that's ready to stick their neck out and say, you know what, my software is good enough that patients can use it directly to make decisions, and I, the company, am ready to be sued.
No one will ever say those words, but they might say them behind closed doors. They'll never say them out loud. I think your point's well taken. If we look outside of healthcare, think about autonomous driving cars. If there's no one in the car, if there's no one controlling the car, it's an AI that's controlling the car essentially. And then something bad happens, which we know it will happen. Who's going to be sued? Normally it would be you, the driver. I wasn't driving. Will society, I suspect the answer is yes, will society make a decision that the benefits of autonomous driving, even though it's going to make mistakes and kill people and hurt people, the risk of that is so much lower than you and me doing it. The rate of accidents is going to go down so much that society will accept the fact that there's some mistakes that are going to happen. And I suspect it'll be the same decision. That I think you're right, that people are like, you know what, the benefits of this thing are so great that society is willing to accept the fact that there's not going to be a human in control. And how do those people get compensation for their injuries? I don't know, but we're probably going to get there at some point. We're not there yet. We're not there with cars. We're surely not there with physicians, with medicine either.
Yeah. Interesting. I think that's probably a good point to transition to talking about careers overall, because we're talking about the future and how it could evolve, where the opportunities are, also where all some of the challenges, unsolved challenges are right now. I'm curious, throughout your own career, what's been one of the toughest challenges that you faced and how did you navigate it?
I think all of us can always learn. I think in general, soft skills are the hardest thing to manage and to learn how to deal with different kinds of people and personalities. And I've certainly run into times where I've tried to convince clients, or when I was on the hospital side, my colleagues, to do something that I knew was right, but I wasn't able to communicate that in the best way, or I didn't find the right mode or the right group or the right people. You learn over time how to do that. One of the things I learned quickly when I was working for Epic, I tried to get a client to do something and I told them this is the best way to do it. And they really didn't want to do it. And I was complaining to one of my colleagues, another physician. I said, man, they just won't listen to me. And I know that this is the right thing for them to do. It's not even iffy. There's a lot of iffy things. This is not one of them. They should definitely do this. And he said, what did you tell them? And I said, what did I tell them? I told them this is what you should do. He goes, oh, you did it wrong. You did it wrong. I'm like, wait, are you disagreeing with my recommendation? He goes, oh, absolutely not. That's definitely the right recommendation. You presented it in the wrong way. And I said, oh, how should I have presented it? And he looks at me and he said, instead of saying, this is what I think you should do, what you need to say is, we have found that successful clients do this. The outcome's the same. The recommendation is the same. But instead of it becoming the session between me and you, like me telling you what to do and you telling me no because I'm not smarter than you and comes to like a pissing match, just saying, hey, we have found, we, not me, we, community, the company, we have found that successful customers do this thing. It works. Those little kinds of tricks, I don't know if it's a trick, but a way of communicating in a less aggressive, more we-centered way really helps you help people.
That's brilliant. I think a really important skill for all of us at the MBA and MBA programs to keep in mind, in addition to all the accounting and the strategy and marketing and finance that we're learning, I think learning how to influence, especially when you're not in a position necessarily of authority or the one making the decision. I think those are really important skills to keep in mind. Just continuing on that same trajectory, talking about people who are going to be future leaders, specifically, again, in healthcare IT, you've successfully made that transition from being a clinician to moving into informatics and healthcare tech. What advice would you give to clinicians looking to make that transition today?
The number one piece of advice that I do give to people is it's important to be a clinician first and an informatics or technology person second. I was just having this conversation with CMIO last night at dinner. If you're a clinician and you're trying to lead other clinicians to do either leading them or leading them to do a certain thing, they want to know that you've walked in their footsteps. And if you haven't done a residency, if you've just graduated from medical school, I think MBA students probably know this. When you graduate from MBA school and you're now an MBA, you don't know anything. you don't know anything. Other people might think you know things, but you don't really know anything. You learned a lot and you have this very wide yet very narrow area of knowledge. And just graduating from medical school, even just doing a residency, if you never really practiced, it's clear to other clinicians. So that would be I don't practice now. I don't believe that you really have to practice actively throughout your career, says the guy who's not doing it. I acknowledge that, but I still can go up to a brain surgeon and say, listen, I'm a pediatrician, not a brain surgeon. So I don't know what you do. I don't know exactly what you do, but I know that you put orders in, and I know that you see patients in the clinic, and I know that you have to document office visits. And I know that you have to send patients to the PACU with orders, and you have to see them up on the floor. I know all those things. I don't need to know what the name of the procedure is or what special medicines that you use. I just need to know that there are special medicines, and I need them to be easy for you to order. And I've never gotten significant pushback from a brain surgeon or anyone else when I presented to them like, hey, I'm here for you. I am talking to you now for you to tell me the special things that you do that I don't understand. But I've written those orders and I've taken care of patients, and I know the pain.
That's really helpful. So you're saying clinicians should lean into that medical background?
Yeah, it used to be that if you didn't practice, no one listened to you. I find that not to be true. That's been my experience. If I can convince you that I understand you and hear you and I'm trying to find the best solution for you, for your problem, that people give me the benefit of the doubt.
Okay. That's really helpful to know. So as we come closer to the end of the podcast episode, we have a handful of rapid fire questions before we get back to our initial question.
Bring it.
These are just very quick, 1 or 2 word responses. What's a great book that you read recently?
Besides mine, I'm pushing my book hard. A book that I read a couple years ago is called Subtract. It's called Subtract, Why Getting Less Can Mean Thinking More. And the premise of the book is that oftentimes when we try to solve a problem, we only think about adding things. What can we add? How do we make this bridge stronger? We have to add things. However, sometimes the answer is taking things away. And it's not just sometimes, it's actually often. That can be the answer. Removing things make things better. And that there's nowhere that's more true than in healthcare. Some things we do that don't make any sense. And to solve the problem, instead of making a different form, how about getting rid of the other form? Instead of making this hoop better, just get rid of the hoop. Why do we even have the hoop? It's a great book. Subtract.
We'll keep that in mind. It's a great book that you read recently. If you had to describe your career philosophy in 3 words, what would they be?
I'll just go with keep it simple. Straightforward, simple. It's always the best.
Perfect response. Final one on the rapid fire questions before we get to our initial question. What's one piece of tech, healthcare or otherwise, you can't live without?
My phone. I mean, come on.
You're just as attached to it as the rest of us.
It's ridiculous.
All right. Well, excellent. Again, thank you so much. And our final question, what's your answer to our opening question? What's something about you that people can only learn by listening to this podcast?
I will tell you something that they maybe could figure out if they read the book that I co-wrote clearly, but I'm a Rush fan, the band Rush from Toronto. We've peppered a few Rush references into the book. And if you're a Rush fan, you would notice that. I actually wrote a blog post once where I put 5 or 6 different song titles into the blog post for Rush. And I was expecting someone to call me on that. No one did. So yeah, if you're listening to this now, I will tell you that I'm a Rush fan and I'm not apologetic for it.
Interesting. Well, that's super interesting. We'll tell people to keep an eye out for it. Again, thanks a lot, Craig, for your time. Really appreciate it. So your book is Designing for Health, the Human-Centered Approach. We strongly encourage everyone listening to this podcast to go out, get a copy, listen to it, and keep an eye out for all the Rush references. But again, thanks, Craig, for your time with us today.
Awesome.
Appreciate it.
Thank you for having me.
All right. Thank you. Goodbye.
Bye.